Hello, welcome folks to the Crisis Residential Association webinar. Hang on here, we're having more people join us, so we'll get started in a minute or so. Welcome everyone to the Crisis Residential Association webinar, One Size Does Not Fit All with Miranda Green. So welcome. We really appreciate your participation, and we look forward to this really informative and helpful webinar today. I'd like to introduce Miranda Green. She's a clinical consultant at TBD Solutions. She has a long history of working in crisis and crisis residential settings, and she's a social worker. So let's take it away, Miranda.
Thank you so much, Carrie. And I echo Carrie's gratitude. Thank you so much for being here today, for taking the time to be present on the webinar. And I'm really excited to talk about this topic today, the risk of a one-size-fits-all crisis continuum. So just a little bit of a sneak peek on what you can expect for us to go over today. I would be remiss if I didn't just talk at least briefly about what the crisis continuum consists of. If you're familiar with me or my colleagues at TBD Solutions, you know that we love to just kind of talk about the richness of our crisis continuum throughout the country and all the different options that are available to communities. So we'll start out there and then talk about the spectrum of sizes of just communities and continuums themselves. And I want to give you a little bit of a peek inside of a unique community that I was welcomed into to talk about and help understand what the needs were of their community through an assessment, and talk a bit about the value of those assessments and kind of what you can expect to happen after when those tools are utilized to make changes and enhancements within your crisis continuum. So as Carrie said, I'm Miranda Green. I'm a social worker by trade, and I'm working as a clinical consultant at TBD Solutions. I'm located in Michigan, and I'm going to talk a little bit more about my great mitten state here in a moment. But as Carrie mentioned, I spent years working in crisis services and specifically crisis residential services. And I really counted myself as a champion of CRU services. I spent time as a direct care staff, as a clinician, and eventually spent some time as a director of crisis services for a large behavioral health company in Michigan. And I had the real pleasure not only of operating crisis residential services, but doing so in different types of communities. So I was overseeing a large crisis residential program in an urban community, in a suburban community, and then had one of the greatest pleasures of my life to actually open a new crisis residential program, and that was in an extremely rural community. If you're familiar at all with the state of Michigan, you may know a little bit about our Upper Peninsula. I have a new colleague who lives in Tennessee, and he got to listen to me wax poetic about the Upper Peninsula for like a half an hour yesterday, because it's a really special and beautiful part of our country that doesn't get a whole lot of attention. But it's very different than really any other part of our country. And so that has informed my experience. I'm also a recipient of services, and I really truly believe that having the right level of care available to me that was close to home and that was available at the time that I needed it changed my life in an incredibly positive way. So as a recipient of services, as a former provider of services, I know that the key to success, especially in the programs that I operated and helped to support, was really because we were able to tailor the programs while still being rooted in best practice. We were able to tailor the needs, the programs to the needs of the communities that we served. So for example, as I said, I live in the Mitten State, and you can see that here on your screen. And the state of Michigan, between our lower and our upper peninsula, has a population of about 10 million people. And one of the programs you can see here on the lower half of the lower peninsula was in Kent County. And Kent County is on the west side of the state. It's kind of a rapidly growing urban area in the state of Michigan. And of our 10 million overall population, Kent County is the fourth most populated county in our state, with Grand Rapids being sort of the epicenter of Kent County in terms of population density. Has 6% of the state's population at 658,000 people, with just 872 square miles. So not a tiny county, but small in comparison to Mackinac County, which is that county that I said I counted myself very lucky to get to spend time in and open a program in. So you probably know our lower peninsula is connected to our upper peninsula via a bridge called the Mackinac Bridge. And the program that I opened was just over the bridge in a town called St. Ignace. You get off the bridge and you take a right, and there's this exit to St. Ignace, and our program was really right off of the exit. And so Mackinac County is a fairly populated county for the Upper Peninsula compared to if you keep going north. And still, although the square mileage of that county is over 2,000 square miles, the population is 0.01% of our state's population. So under 11,000 people live there. And so if I would have assumed that what worked well in Kent County was going to translate perfectly in Mackinac County, I would have been like chased over the bridge with pitchforks, because the communities are very different. And while both programs were still very much rooted in solid clinical practices and strong processes and procedures, the way we talked about care, the way we marketed care, the sorts of groups that we offered, the way we went about discharge planning was very much tailored to the needs of that community. So it brings us to this question about one size fits all. And I don't know about others, but I think legging wearers will feel me on this. Throughout my adolescent and adult life, I've had a varying relationship with wearing leggings. But in full transparency, I'm 18 weeks pregnant, and so I'm very good friends with leggings at this point in my life. And again, if you're familiar with wearing leggings, you're going to know, I think you're going to be able to relate to this. When you're shopping for pants/leggings, and you are looking at different sizes, and you pick up a pair of pants and they have that tag that just says OS. So it doesn't have the size on it, but it has the OS indicating one size. I know, especially right now in my life, I'm like, okay, these are not the ones for me, because just because I can squeeze into something does not make them a good fit. And I will say maybe the caveat to that for me as a kind of tech impaired individual is that a lot of times I feel like Control-Alt-Delete fixes most and can fix most of my kind of tech issues that I experienced day to day, which sometimes are plentiful. But in life, when we're dealing with people, we just simply are not one size. Our needs are unique as individuals and as whole communities. And while I think it's really important in healthcare, and considering behavioral healthcare part of that as well, that we have some go-to solutions and then we know what works really well overall in our country, we also need to be aware of when we need to adjust, when we need to really do some reflection, and when we need to just completely diverge from our go-to solutions. So this idea that one size fits all, or even that one size fits most, I would go as far to say is just a fallacy. Something may fit, we may be able to squeeze ourselves into it. That doesn't mean that it fits well. And unfortunately, there are consequences to trying to make ourselves fit into one size all over the country. The consequence is that when the default is a mismatch in our own community, it can lead to struggles within relationships in that community. Trust starts to erode, and then doubt takes over. And the last thing that we want when we're trying to enhance and strengthen our crisis continuums is for doubt of the community, and for especially those served, to take over when they're looking at options for them to safely be served through their crisis, presenting crisis. And so, as promised, I want to talk just a little bit about, like I said, kind of the richness of what's available to us as providers and as community planners as we think about what's available for a crisis continuum. And so a couple caveats I want to give are that when I'm talking about a crisis, I'm talking about a behavioral health crisis. So that's something that may be rooted primarily in a mental health crisis or primarily in a substance use crisis. Oftentimes we know that those are usually co-occurring and they're happening together in some way. I'm talking about adults and youth. And so most, if not all of these options are available or have been studied what the best practices are for them for both youth and adults. And when I use the word community, I'm really talking about what community means for you in the seat that you're sitting in today. So if you're a provider, you may serve an entire state. And so you might be thinking about community as a statewide group of folks. You may serve one county, and so that might be the community that you're thinking about. You may serve one large or small city or town. That might be the community, or it could be a region where it's, you know, an amalgamation of different counties. And so community is just really the area in which you are working and the people in which you are serving. So if you get back to this graphic you're seeing here on the screen, have somebody who's presenting in crisis, and we know that these don't always happen in a predictable order. We love for folks to start out leaning on those kind of least restrictive settings and staying, you know, in the community if at all possible. And so we start kind of with this idea of a crisis call center. We know crisis call centers can have incredibly outstanding outcomes, and that most folks can be de-escalated on a call without having to be required to enter into a higher level of care if that crisis call center is operating really well and has great training and great support for their call takers. But that doesn't mean that it's going to happen in a sequential order where if they're not able to de-escalate, they're automatically going to call mobile crisis, and no one's going to go to the psych hospital until they go through all these other options, right? Everybody is unique. Communities are unique. What's available is unique. And so it can look different for different people at different times. But there are a lot of options for us to consider when we're thinking about how do we want to grow and enhance the continuum in our community. So I mentioned crisis call centers. We hear lately, I will say, mostly about crisis call centers, which is no surprise as we have 988, you know, as such a hot topic, and funding and attention available on that level of care. We're hearing quite a bit about mobile crisis. Psychiatric hospitals will never not be an important part of our continuum, even if sometimes misunderstood. And most of us believe that no, just adding more psych beds to our communities is not the answer. Some psych beds in our communities is certainly important. And then this 23-hour observation level of care is getting more and more attention in the last couple of years as well. And it goes by different names. We're really it's a problem in the world that we live in of behavioral health crisis. Sometimes it's the 72-hour observation programs. Sometimes it's called a crisis stabilization unit, which can get a little bit confusing, but oftentimes it's a very short length of stay that's diverting folks from going to the emergency department as a first kind of entry into the system. But there are so many options outside of those. So we also have psychiatric urgent cares, peer respites, which you could hear us talk about all day, services operated by people with lived experience, making admission decisions, really spending time de-escalating crises for folks without a focus on psychotropic medication, partial hospitalization programs where people can be experiencing a very acute crisis, and the focus is very much on a wraparound service and a lot of group therapy, but individuals are able to leave in the evening and go back to their home setting for the night. Crisis residential units, where the average length of stay is about 5 days on a national average. That can be used to divert individuals from the psychiatric hospital or shorten the length of stays as a step-down option. Psychiatric hospitals, and then state hospitals or state institutions, which still exist throughout the country. I got a little overzealous with my clicking. So I'm not going to read this to you. I'm not a history buff by any means, but some things that sort of stand out to me in more recent history in the last 10 to 20 years, you can see here up on the screen. A lot of what we've seen in terms of progress with 988 in the last couple of years started in 2005 when the Lifeline network was created through a network of local call center providers. Something else that's really exciting that I always like to shout out is a few years after that, in 2017, Mental Health America was able to create a national certification for certified peer support specialists. A couple things that are super important. We've got some information up here about 988. And between 988 being recommended by Congress and it going live this summer, right at the start of the pandemic, something really important in sort of the history of our behavioral health system in this country is also that SAMHSA published guidelines for behavioral health crisis care. And those have gone on to inform program development. Those have gone on to inform best practices, but they've also played a large role in informing ongoing funding structures at the federal and state and even local level for behavioral health services. The national guidelines, I'll say in my opinion, are a fantastic tool. The more available best practice guides and research that we have during this time where crisis services are really in the midst of like this long awaited and well-deserved time of spotlight on a national level, the more the better. It's really important that we have these tools as a way to make assessments and as a way to be informed. But it's also incredibly important that we don't see one tool as a fix-all for every community. So some things that I had started to notice in the last couple of years, and was really highlighted through the launch of 988, was that a lot of grants, I saw language being written into grants or into bills, and even some of Vibrant's language around 988 referred back to the national guidelines for behavioral health crisis care. And oftentimes what that did was attach 24/7 mobile crisis response to our call centers. And I love and believe in both of those levels of care, call centers as well as mobile crisis. But what I found to be harmful was assuming that every community had the resources or even the need for 24/7 mobile crisis staffed by at least 2 clinicians, two staff, one of which being a licensed clinician, and making those assumptions in order for them to even receive funding and support for the sustainability of their call centers. And so what I had pondered about that kind of prompted thinking more about even this kind of a presentation is that in our country, when people are in positions of power to create legislation and to shape requirements for large funding opportunities, if it's informed and shaped by a single document, that leads me to be concerned that things are moving too much in the direction of one size fits all. So I found it really helpful to kind of learn about unique traits of other communities. And Carrie, I might ask you for your help here. I think that everybody has an opportunity through GoToWebinar to use a raise hand feature. So rather than like physically raising your hand in whatever room or office you're in right now, which you're welcome to do that too. I just won't be able to see you. I want to try out, it looks like we've got about 58 people here today. Let's see how many people we can get to successfully use the raise hand feature.
We're starting to see some hands. Do you want them to raise hands for anything in particular?
First, we're just practicing. Like, let's just make sure everyone knows where that is and get that hand raised up. Okay, I see a bunch of green hands.
Yes.
All right, we'll give it another second. If you're here with us and listening, click that raise hand feature just so that I know it works. So we're practicing raising the hand, and now we're going to practice putting the hand down. So I think you click it again and it will lower your hand.
It's working.
All right. So we should have no raised hands right now. And I want you to raise your hand if in the community, however you define community, if you consider your community, or at least a portion of it, to be rural. Raise your hand. see a lot of hands raised for rural. More than I was even expecting. Okay, lots and lots
Round
and lots of
14,
raised hands.
Miranda.
Okay.
Round
All
14.
right. So you can put your hand down and then raise your hand if you consider your community or a portion of the community that you work in to be urban. How many are we looking at for urban, Carrie?
About 18.
Okay. What about if you consider a portion of your community or the entire community to be frontier in nature? So less people per square mile than even rural. Just a couple hands for frontier. It's so interesting when we're in different parts of the country. When I get so surprised where we have tons and tons of rural hands up or tons and tons of urban hands up. So we've got a pretty good mix here. So we'll think of some other traits that could make your community unique. Raise your hand if the community that you work in, you would consider it a college or a university town. Okay, more hands there than I was expecting as well.
Round 12.
You can put your hand down. What about where there's a large population in your community that folks are, they don't speak English? This is fun to get to see hands go up too, because I get to see some of my friends from around the country, their name pop up here.
Round 11.
Quite a list there as well. Okay. What about lack of public transportation, if that's an issue that you see in the community that you are serving?
Seven.
Okay. So I won't make you keep raising your hands, but these are some of the considerations that are really important as we think about unique traits of a community. Frontier, rural, urban. We hear a lot about those. College or university town, there's going to be special considerations about population changing during different seasons and the age of the individuals who are living in that community and which resources are available to them, the language that folks speak, but also thinking about, is your community a regional? Is there a regional approach to your behavioral health services where there's not just one county, but 3 counties or 5 counties or 8 counties or more? If there's poor internet or phone service, that changes our approach when we're talking about telehealth and virtual options. Lack of public transportation is a really hot topic we're trying to figure that out all over the country. How do we make these services easier for people to access when there's just a real challenge with a lack of public transportation? CCBHC sites is something to consider. And then something that maybe doesn't get talked about quite as often, but I know is a challenge for many of us, is this understanding of the dichotomy of kind of who's the boss and how that looks different all over the country and even within states. So your crisis services may have a heavy involvement from state legislature. It could have a heavy involvement or be funded by your health department, or have a lot of involvement by law enforcement, while other communities have no involvement from law enforcement. So the ways in which our communities can be unique is kind of a never-ending list. So like I said, some of the things that we talk about the most often in ways that the most common solutions don't necessarily work as a one-size-fits-all solution are for those rural and frontier counties. When there's a large catchment area variance, funding systems and opportunities for grants and ongoing sustainable funding variances, and then state requirements are different all over the country.
Miranda,
So
we've got a couple of comments here from the folks. Susie covers the entire state of Kansas, and so everything applies. Brenda covers 9 counties. Transportation and internet connectivity is an issue in some of those counties.
Yeah, and they're not alone. I know that doesn't help solve those problems. You're definitely not alone in those experiences. And I think that's even demonstrated here in this story that I want to tell you about. So I have had and continue to have the great pleasure of sometimes I would consider it kind of setting up dual citizenship in Chillicothe, Ohio. So for anyone who knows anything about the relationship between my home state of Michigan and the state of Ohio, you know this is a very big deal that we've been welcomed with open arms for the most part into Ohio to engage a partnership on this topic, how to best grow and enhance their crisis system in a way that is sustainable and works really well for their community. So in early 2021, my team was brought into what's called the Paint Valley region of Ohio. You can see the state of Ohio here up on the screen, and the green counties down in sort of southern middle Ohio is the Paint Valley region. And it's made up of 5 counties: Fayette, Pickaway, Ross, Highland, and Pike. And we were brought in to complete a crisis system assessment. And like I mentioned, help to make recommendations for how their unique community and communities, because we were looking at it kind of from a county approach as well as a regional approach, should shape their crisis services. And so, like I mentioned, you know, not only is the region unique and that that's missing a number, but it's about to, you know, halfway between 2,000 and 3,000 square miles. So it's a pretty large catchment area with a total population between those 5 counties of 234,000. And then each of those 5 counties are very unique as well. So a couple of examples I can give you is when you look at Pickaway County right there at the top, they're considered a bedroom community of Franklin County. So you can see on other maps that Franklin County is directly above Pickaway County. And why that is significant is that Columbus is located in Franklin County. And Columbus is the state capital of Ohio. And so while the other 4 counties of their region are considered Appalachian counties in the state of Ohio, Pickaway County is not. And so they differentiate themselves oftentimes from the other counties in that way. Fayette County has a large farming community. Pike County, which you see at the very bottom of the region, is actually the 2nd poorest county in Ohio, and tends to be sort of because of historical reasons, like we take care of our own. They don't need a lot of outsiders to come in and help solve issues. And then Ross County in the middle is actually the 2nd largest landmass in Ohio. So it's the most population dense county in the 5-county region. It has a pretty much half and half makeup of folks who would consider themselves progressive and others that would not identify that way. And so there's a lot of difference even just in Ross County itself. So you see a lovely lady here on the bottom of my screen, and her name is Penny. And she is the leader of their AdamH board. And so that's the entity that helps to coordinate and pay for substance use services and mental health services in this region of Ohio. And Penny tells this really great story that I think was very telling, where she spent some time in their great capital, Columbus, talking to some legislators about different issues that she was experiencing, or folks who lived in her region were experiencing, one of which being transportation. And she said that what she heard from many of the legislators as a solution was, have you heard about all the success people are having using rideshare apps to get folks from appointment to appointment or program to program, like Uber or Lyft? And so Penny challenged those legislators to go ahead and get an Uber and take it to Pike County. And then when they get to Pike County, get back on Uber and try to find an Uber driver to get them back to Columbus. Because in their 5-county region, Pickaway County is the only one that does not have internet access issues that are widespread. And so there are solutions that we talk about on a national stage that just simply do not work for many of the communities throughout our country. The Alcohol, Drug Addiction, and Mental Health Board, or AdamH board, in this region has a 14-member volunteer board of directors, and they have 9 paid staff. And for a fairly rural and large 5-county region, they actually have a pretty rich makeup of provider agencies. So they have a mental health outpatient provider in each of the counties, which they're very proud about, as well as a substance use disorder outpatient provider in every county. They have 2 SUD residential facilities that serve both men and women. They have an 18-bed mental health residential program. And then they have a small hospital in every county, and one of which has 12 adult psych inpatient beds. So they do have some services offered. Something else that's unique, or at least it was unique to me because it's different than the state of Michigan and Ohio, is that most of these ADAMH boards are able to fund their services. And you can see the purple line is the largest in all of these fiscal year examples through a property tax levy. And so when you hear Penny and other leaders of ADAMH boards talk about how they're making decisions about changes and enhancements to their crisis continuum and their behavioral health continuum as a whole, they really feel like they answer to the community because they're not being funded by a whole lot of grants. They're not receiving much state and federal funding. And the people in the community through their property tax levies are really purchasing those services and paying for those services. So before I get into a little bit more about the value of the assessment and some of the elements that can be helpful in the assessment, I just want to share an example that I think really exemplifies why this is so important. So you can see on the left-hand side of the screen that it's been fairly steady, except for, of course, during fiscal year 2020, the number of crisis services that were delivered in their region. But then if you look on the right side of the screen, where we're looking at the pre-screens, they start to go down and have a significant reduction in so far in fiscal year 22. And so if consultants like myself came into that county and just looked at this data and just analyzed it in a vacuum, we might, come to some of our own assumptions around folks not going to the emergency department for pre-screenings before they enter crisis services anymore. But because there's such a focus and really the most important pillar of successful assessments is bringing the community together and really having casting a wide net as to who's a part of the community and what kind of representatives you want to have as part of these conversations. We learned that in 2021, the local hospital, the one that had the 12-bed adult inpatient unit, they bought 3 of the other hospitals in the other counties. And after that happened, they began to transport every person with a presenting behavioral health concern to the emergency room that was attached to the psych unit. And rather than calling the crisis provider to do these hospital pre-screens, which is where these numbers come from, they started to do their own screening. And so just looking at the data, it was really telling a false story. The nuances and the politics of the region, which we would not have known without developing those relationships with stakeholders from all over the region, told the rest of that story. And so the moral really is that the voice of the people who live in that community and really love that community, they have to be involved in the assessment and the decision making for it to be all encompassing and something that's really sustainable and rooted in fact. So as we mentioned, popular models just simply do not fit every single community. They're a great starting point, but we have to be flexible. And a lot of times what's concerning is that they don't, if we lean only on a model or a recommendation through a large entity like SAMHSA, we're not considering other important factors like data-driven decision-making. So if the utilization and population or population density in a community don't support the sustainability of a service, it's really important that we don't just make a knee-jerk reaction and open those. So a great example is that legislation and regulations require different staffing models, different oversight, and different bed sizes all over the country for different crisis services. So in many states, they would require at least a 6-bed unit for an adult crisis residential unit. And so if through an assessment, you find that a community could only sustain financially 4 crisis residential beds, the community is left with this decision about whether or not to open a program that has 6 beds, because they can't go any lower than that, without sustainability, or to pivot and increase other community services, like maybe they're going to increase their mobile outreach and not have a residential option. So the decision on which is a better option has to be dependent on community needs and through an assessment of data. Because the fact of the matter is that we are really going nowhere fast without community buy-in. Our systems are already so confusing. They're so hard to navigate. And historically, they were not built and developed in a way that was really rooted in inclusion and in equity. And so while there's a light shining on crisis services and the money is flowing and funding opportunities are higher than they've been in the past, we have an opportunity to make positive change by including the community, including key stakeholders in education, in discussion, and in decision-making around our crisis continuums. So the purpose of us bringing together this large community collaborative in Paint Valley was really twofold. It allowed us to review current practices that were related to how everything functioned at that time in their community. Without us just looking through source documents, we got to really hear how it was actually working for adults and youth in their region. And something that was really sustainable for them, which was exciting to see, is that it also provided avenues where they could have great communication between organizations throughout the region. And so they had availability and access to one another to give updates, to ask questions, and to problem solve in a lot of ways. Carrie, any other comments or questions before we move through talking about the assessment?
Yeah, George had a really interesting comment about in the chat about access is the problem and the issue in every community. And he says, but even when we have access, the help isn't available because in his community, person has to pay money for services, the free services for those without income, homeless, or without health care. What they can access is slow, not timely, and less than mediocre quality. It's embarrassing. It's so he's an advocate for these folks, and we need someone who can function to tear down the barriers for them. So, access and you know, it's interesting. I know in some communities, crisis residential services aren't available for people with insurance. They're only available for impoverished people. So there's a real unevenness. Thanks, George, for that comment.
Yes, thank you, George, and thank you for all that you do. Folks like you who are a voice for the people who need it and an advocate are definitely the kind of folks who have to be involved in these kinds of assessments. And sometimes these can grow from a grassroots effort so that we have some evidence-based practice and some data to root our recommendations in. You might not feel like this, George, you may be more energized than me, but I mentioned at the start, I felt like I was a champion of crisis services in my organization. And I would sometimes feel myself feeling very burnt out. Like, am I the only person who's like talking really loudly about how we need to expand these services or enhance these services? And I always did find that I had the most success when I was partnering with others and when I was coming in with some like evidence to back up my very passionate claims. And so go ahead, Carrie.
Oh, I was just going to say, he also commented that it can be a non-system of care. We allow our organizations to remain in silos.
Yes, unfortunately we do. Hopefully that continues to improve. So the components of an assessment, I think the more components we do, the stronger the assessment is. But any one of these things can be very helpful as pieces of those kind of evidence that I just mentioned that can go along with your really passionate advocacy. So I'm going to tell you a little bit about our approach in hopes that it inspires creative problem solving and assessment engagement by you and your team and your community. So we engaged, and I'll tell you more about these in detail, but just as an overview, we engaged a gap analysis. So we were looking at services available currently in their region and in each county against best practices, and not just whether or not those services existed, but if they were operating to the fidelity of a best practice recommendation. We were also lucky enough to be able to engage some asset mapping, which I'm excited to tell you more about. Of course, always rooted in industry research. What are those published best practices? What's the evidence-based services that should be happening, taking place that lead to really great outcomes? And what are some of the kind of superstars in the system around the country doing to make these things work really well? So we also engaged probably the most important things that we did, site tours and structured interviews with people served, as well as advocates and providers of behavioral health crisis services throughout the region. We analyzed available metrics, and we also always like to take into account network adequacy. So, of course, variation is expected based on community needs, like duh, that's the whole point of our conversation today. But in a gap analysis, we do take published best practice recommendations and we use them to serve as a benchmark when we're considering how to best enhance, local crisis networks. And so most often the two primary sources that inform our gap analyses at TBD Solutions are one, the 2020's National Guidelines for Behavioral Health Crisis Care, so the best practice toolkit, but also the roadmap to an ideal crisis system published in 2021. And so when we do these gap analyses, we have to learn more about, again, whether or not they're just operating, but also how they're operating and what their outcomes look like. So we consider features of those best practice models against the characteristics of the services in the community. And then based on that comparison, we might be able to identify where they're doing really great or where there's some disparities, and that helps to inform considerations and potential resolution in the future recommendations. So when we're engaging asset mapping, one of my favorite things to do to make really informed decisions when we're thinking about gaps in crisis continuums in communities, you look at the network of community partners and providers. So in Paint Valley, we had looked at each of the counties separately rather than in a regional approach specific to asset mapping, because we found that their systems and the way that referrals were happening and what kind of entities were involved in crisis care varied so much from county to county. So we did a separate asset map for Fayette, Highland, Pickaway, Pike, and Ross County. And when we looked at the partners, we were really able to narrow it down to these kind of 4 buckets for people when people were in an acute behavioral health crisis: the hospital / emergency department, the mental health providers, law enforcement, and then substance use providers. And each of those partners had, of course, their own mission and purpose. They had their own funding sources and oversight. But when we looked at all of them together as kind of a network, they were conceptualized as a single complex crisis network that was inclusive of adult and of youth services. And so we had those 4 distinct provider types. And we were able to kind of ask 2 questions as we completed our graphs. What types of providers are currently part of those crisis networks, and how do they interact with one another, not just in the behavioral health system or the healthcare system, but how do they interact with another during an acute behavioral health crisis? So we had a number of focus meetings, and then we were able to use the data and what we learned to develop network graphs for each of the 5 counties. So those can look a little overwhelming and maybe like a solar system or a spider web, like what you see on the screen there. But the network graphs illustrate the relationship between assets, which are the different provider types, and the connections between those assets. So in what you're seeing here on the screen, the size of the circle is relative to the number of connections that they have. So this is a really nice way to visualize how often we're really using in connecting services to one another. And so what we see almost always in network graphs are that hospitals, EMS services, and oftentimes law enforcement will have the biggest circles because we've created systems around them. They're really integral to the way that folks are connected to services. So those are incoming and outgoing connections that the providers are mapped to. We were also able to learn about incoming connections, outgoing connections, and the impact of those outgoing referrals. As I mentioned before, maybe one of the most important parts of an assessment is not going off of assumptions, but engaging interviews, making those as structured as possible so that we remove some of our bias and we're asking people similar, if not the same questions. And we also had the opportunity in Paint Valley to do site tours of these 3 beautiful programs that you see here up on the screen. So we were able to visit the hospital and see the way in which they've made changes to their emergency department for behavioral health patients. That's really innovative and quite frankly, very beautiful, as well as their inpatient unit that says 14 bed, but it should say 12 bed. They have a 12 bed inpatient unit. We also got to see their CSU kind of like program and their partial hospitalization program. And then finally, the crisis center that was located in Ross County, where their regional call center took calls. For our metrics review, we really focused on utilization data as well as satisfaction data. So I want to give you kind of some of the highlights of what stood out to us in this county in terms of utilization and satisfaction data. So we found that a staggering 49%, so almost half of the people who went to the emergency department in their region required a behavioral health screen. So of course this led to more conversation and more questions on our behalf. Do they have an incredibly high behavioral health need in their region? Is the tool that they're using in their emergency departments kind of hyper triggering the need for a behavioral health screen? So it results in some more fact finding and question asking. Their CSU-like program, their length of stay ranged from 1 day, which we see in all those types of programs, all the way to 194 days. So their average length of stay was 34 days, which is really unusual for those types of programs on a national level. So again, caused us to ask more questions. And what we learned was that this was really a safety net for all types of populations. And because they adjusted their approach to the needs of the community, and there really wasn't an enhancement or a growth in the continuum in quite some time, they continued to adjust and say yes and open their doors to more folks as they needed it. But at times that could interrupt the integrity of the treatment modalities that would be used in that type of level of care. Some really great data that we came across is that their call center averaged an answer rate of 93%, which is incredibly high. Like we're hoping for a 90% answer rate in a couple of years, not a national level from 988. So they were already there. And then what we found that was more disheartening, but something that was kind of easy to make some recommendations for change on, is that there really hadn't been much of a focus or value placed on satisfaction surveys from the as folks discharged from crisis services. So it wasn't that they had a low satisfaction rate, their completion rate was not even to 2%. So that was sort of low hanging fruit for the community to be able to rally behind, and that this is something that we can definitely improve so that we can actually look at the satisfaction data and see where we have room for improvement. A population health analysis was also conducted. And so you see 14 different county characteristics here on your screen. And we use those county characteristics to find 10 counties throughout the US that were identified to be the most like each of the 5 counties in the region. And so this is really useful in your research because it allows you to look for success in communities that look like your own, outside of just like, we have a similar population, but based on a plethora of other factors. that make our home communities so very unique. And each of these 14 county characteristics that you see here on the screen are all available, mostly with census data. And so it's publicly available data. Carrie, any other comments or questions before we move forward?
Yes, Leanne asked for the gap analysis document. And then we had another comment from George about call center data. Our populations live with a high level of post-traumatic stress and COVID. A thought that primary care provider teams should be addressing behavioral health within their clinical processes.
I'm talking while I'm muted. Someone had to do it. Leanne, I just realized that I don't have my contact information at the end of this webinar today. So I'll give it out though, because I'd love for you to reach out to me, and anyone else is welcome to reach out with any questions or requests as well. So I'll make sure to provide that at the end. But to the last point around kind of integrating care, I think providing these kinds of assessments, especially the community collaborative portion, is a great way to open the door to not just have those conversations, but to help demonstrate the need for those kinds of changes and those kinds of enhancements in your own communities. What we see a lot of times are that assessments are completed, and a lot of times they're great assessments, or folks come in and analyze data throughout a community and say, hey, we've seen some areas for improvement, and people read a report and they say like, this is really great and helpful, thanks for doing that. And then it kind of gets tucked away and things get really busy and it's business as usual. And so by bringing the community together, it's giving everybody a voice, and it really kind of holds leaders' feet to the fire to actually engage in change, rather than someone just completing a survey, you know, in the privacy of their own office, submitting it, and then feeling like, man, I do all these surveys and nothing comes of it. There's more face time and like I said, kind of just community accountability. So that can be a benefit or an impact of these kinds of assessments as well. So in short, the assessment went really well in Paint Valley, and something that we were really excited about was just continued engagement and collaboration from so many different community partners, whether that be folks representing primary care offices, law enforcement on a city, county, and state level, crisis providers, outpatient behavioral health providers, advocates, NAMI, school systems played a huge role in the assessment in Paint Valley. They have a ton of schools, and also the schools were getting really creative with the way that they were combating behavioral health crisis for youth. So they had a lot of fantastic input, and we're really eager to share. And so there's just so much to learn from different folks, kind of outside of what we maybe normally think about as having a voice in these assessments. And so what's really cool in Paint Valley is that they're actually in the process of enhancing their crisis continuum right now. So they're right in the midst of an RFP for a 23-hour observation unit. And there will likely be other RFPs to come in the future to continue to grow in the right way and grow the right size services throughout their continuum. So with that, I think we have maybe a little less than 10 minutes. I'm happy to answer any other questions. I am going to figure out a way to put my email here up on the screen really quick so everybody has access to it. So while I'm doing that, Carrie, hit me with any other questions or comments that came up, or any thoughts that you have, because Carrie is a crisis wizard as well.
Just appreciate the idea of working with the community directly, instead of trying to put a square peg into a round hole kind of a situation. And there's an awful lot that can happen over the phone, in person, to divert someone from a very expensive, very traumatic hospitalization. And so Crisis Residential is all about getting the right people to the right place and not making treatment traumatic.
Amen.
It looks like that's all the questions or comments we have. But some really good interaction, and I think it's fantastic to give light to some of the more rural, spread out communities considering crisis.
Absolutely. Well, thank you so much for having me, Carrie. Thank you all again for taking time out of your week, especially right before the busy holidays. My email address is right here up on the screen. You're welcome to reach out anytime. I'd love to talk more about this with you. If there are resources you're looking for, I'm happy to try and connect you with the right resources. And I hope you have a great rest of your day, rest of your week, and a very happy holiday.
And I encourage you folks to check out Crisis Residential Association and our website, Crisis Residential Association. You may want to join us because we're a fantastic group of people all over the country.
Thanks, Carrie. Bye, everybody.